Yes, sir.
Right, okay. So last week we were seeing about the structural relationship of heart and the lung and how they impact each other, both in terms of communication, in terms of occupying the space in the chest wall, how the blood in the heart each other. Like if the heart is pumping at a higher thing, like if the systolic pressure is more blood will be pumped into the lung, and there will be an impact on the pulmonary system. Similarly, let's say if the patient is on a ventilator and we are giving a higher tidal volume, it will be occupying a lot of space in the chest wall, and the intrathoracic pressure, the pressure in the chest wall will be elevated. As a result, the blood which is coming back to the heart from the venous system, like if you are seeing this thing, these are the blue color, whatever you are seeing here are the venous system, right? It is carrying the deoxygenated blood back to the heart from the rest of the body. So this has to be having a low pressure. The pressure outside the chest wall should be higher than the pressure in this greater veins like inferior vena cava or superior vena cava. Only then the blood will be coming back to the heart. So if I'm having a higher peak or if I'm maintaining a high pressure in the ventilator, these vessels will be squeezing blood from to enter into the circulatory system or to enter into the heart. So this is the impact of the lung on the cardiac output. Even when the heart, when the blood which is coming back to the heart is less, very less volume of blood is available for the heart, and the heart pumps this blood. The systolic pressure will be dropping because it's really receiving a little bit of blood, so it cannot generate adequate pressure. As a result, the BP will also be falling. So many cases or instances, you people would have seen in the field that when they are increasing the PEEP in the ventilator, there will be a concomitant impact on the blood pressure. So when the BP is falling, one of the things the clinicians will do is, other than the medical management, they will try to reduce the PEEP so that the pressure in the intrathoracic region comes down, and then more blood starts flowing into the heart. And when the blood volume, the diastolic volume, end diastolic volume that we call it, when the end diastolic volume is adequate, it stretches the cardiac muscles. It's like an elastic band. Like if you are stretching the rubber band, the more you stretch, the more it will rebound back with force. So like that, when more blood comes into the heart, the heart will pump it with more force. As a result, more pressure will be generated, and the systemic blood pressure will be improving. So that's how they are impacting each other. Okay. Now we also seen the structural relationship of the alveoli and the capillary blood vessels. So these are the vessels which are coming from the heart, and then they are dividing into a network called capillary, and each capillary is lining the alveoli very closely. They are lining, and they are separated by just a basement membrane. Very thin membrane is separating, because this is a very small ultrastructure. Not that we can see it with the naked eye. We need microscope to see these structures. These are very small, of the order of let's say 5 microns to 10 microns. So that smaller organ and that small thin structure, they are separated by just one cell, and easily the gas can flow from the alveoli to the blood, or from the blood to the alveoli, in both the direction. Depending on the concentration gradient, it can move from alveoli to the blood in the capillary, or from the blood to the alveoli in the lung. Okay, so it depends. Like carbon dioxide is rich in the blood, so it will be diffusing into the alveoli, whereas the alveoli will be rich in oxygen because of the inspired breath, and that gas will be entering into the capillary. So this is the gas exchange we are talking about, and the very purpose why we are using the ventilator. So when we go deep into it and try to see at the ultrastructure, Like see, this side is the alveoli, and this side is the capillary. This is the blood vessel. You see here a RBC, a big RBC. This is an electron microscopic zooming of the alveolar capillary structure, and see that they are just separated by a thin membrane. This is very thin. Okay, on the PowerPoint presentation, I'm showing it because it is enlarged several thousand fold. But this is a very thin structure, and in the center you have got the basement membrane. This side is the alveolar cell, and this side is the endothelial cell of the capillary or the blood vessel. So the gas has to move from this side to this side, and any gas which is at a higher concentration on this side and a lower concentration on this side, by simple principle, the diffusion principle, this will be moving from high concentration or high pressure area to a low pressure area. Similarly, carbon dioxide, which is rich in the capillary, will be moving in the opposite direction to the blood, to the alveoli. And in the exhaled breath, those carbon dioxide will be carried out of the body. So we had seen that how this systemic circulation from the entire body, after the body utilizes the metabolic need of the body needs a lot of oxygen, and that's why we are inhaling oxygen. When the body uses that, the deoxygenated blood comes to the right chamber, right, the right ventricle, and also we discussed that the pressure in the right side of the heart is lower compared to that of the, because see, this is pumping the blood to the entire body with very high pressure. That is the normal systolic pressure we are talking about, and the diastolic pressure. That is about normal BP is 120 by. That is applicable on the left side of the heart. But on the right side, when the right ventricle contracts, it goes into the lung. Only organ this has to feed the blood to a very the pressure this side can achieve is 20 to 30 millimeters of mercury. That's it, not more than that. And the diastolic can be as low as 3 to 5 millimeters of mercury. So when this is pumped, this goes to the lung and then divides into this thing, goes to the alveoli, gets gas exchanged, releases all the carbon dioxide to the blood, collects all the oxygen from the blood, and then it comes back, into the alveoli and collects all the oxygen from the alveoli, and the blood comes back to the left atrium. And there's a trigger, and the left to supply for the entire body. There is a huge resistance, and when it has to pump against the resistance, the muscle thickness, the left side of the heart muscle thickness is also pretty strong and big compared to that of the right side of the heart. So when this pumps through the aorta, it goes to the systemic circulation. So what I wanted to say, just a recapitulation of last week's thing, is that there is two types of circulation exist in the human body. One is the systemic circulation, which is primarily managed by the heart and the rest of the body, and then the pulmonary circulation. This is the cardiopulmonary system. And when we talk about ventilator, this system is important for us because the ventilator will reach till here, and the very purpose of giving a ventilated gas is that the mechanical ventilator has to ensure the gas exchange continues and the carbon dioxide is removed from the body. We add oxygen to the blood, and that is coming to the heart and supplied to the entire body. Seeing the concentration of gases in different side of the heart, like after the body utilizes the oxygen, the deoxygenated blood will be having a less amount of oxygen. The partial pressure of oxygen in the pulmonary artery is very less. It's about 40 millimeters of mercury, whereas the carbon dioxide concentration is high because the end product of any metabolic reaction happens in the body is carbon dioxide and water. And water is eliminated through multiple routes, by evaporation, by sweat, by urine, by defecation, by transpiration. There are multiple ways through which the water is removed from the body. The carbon dioxide has to be eliminated through the lung. So the deoxygenated blood coming from the right side of the heart will be rich in carbon dioxide and it will be very poor in oxygen. Okay. After it goes to the lung, the gas exchange happens, and then what happens? You see that from what it was, the PaO2 on the venous blood system was 40 millimeters of mercury. Like if you are taking this blood from the central vein and send it to ABG, in the ABG report you will be seeing the partial pressure of oxygen as 40. Whereas if you take the blood from the artery, from some of the main artery in the body, usually that's what they do. ABG means arterial blood gram. Okay, so if we take the blood from here, ideally it is called as venous blood gram, but the device used to measure this is same, and that device is called ABG device, so we go by that name. So the blood collected from the vein will be having a less of oxygen, whereas when you are taking the blood sample from the artery and sending it for ABG analysis, in that you can see there's the value for about 100 millimeters of mercury. The arterial system is about 60 millimeters of mercury. The oxygen in the alveoli will be flooding the blood in the capillary system and increase the concentration to as high as 100 millimeters of mercury. What I mean by normal condition is without ventilator, without mechanical ventilator. Normally how you and me are breathing, we will be having 100 millimeters. If I am using a mechanical ventilator and if I am increasing the FiO2, then this value will not be 100, it may be more than 100. So that's what you see that in some of the patients you can even see 200 millimeters of mercury on the PO2, the partial pressure of oxygen. That is because of the excess pressure we are putting into the, excess partial pressure of the gases we are introducing into the alveolar system. So there is a huge gradient, huge pressure gradient available between alveoli and capillary. That is between here and here. I'm putting huge amount of oxygen on this side. So because here the oxygen is only 40 millimeters of mercury, normally at 21% of FiO2, that is a normal air we all breathing, this will be ensuring 100 millimeters of mercury process here. But when I'm keeping an FiO2 of let's say 40 or FiO2 of let's say 60 or even 100 for example, then that means the partial pressure on this side should be proportionately increased. For example, if I am keeping 100 here, then what is the total barometric pressure? Anybody knows what is the atmospheric pressure? One atmospheric pressure is equal to how many millimeters of mercury? Can you unmute yourself and anybody can tell me?
760.
Yeah, 760, right? So 760 millimeters of mercury is the atmospheric pressure at the sea level. So this again changes at the depth of this thing. If I am going in a high altitude, like taking a flight and going higher or climbing a mountain, a high altitude mountain, this scenario changes. But we are talking about the pressure at the sea level. At the sea level, it is 760 millimeters of mercury. So that is the total pressure. And if in that total pressure, 21% is oxygen. Okay, so that means approximately it comes to 150, right? 21% of 760 is about approximately 150 or 154, right? Just calculator for the clearance here. So we are talking about 760 millimeters of mercury, and of this we are talking about 0.21%. 21% is oxygen. So partial pressure of oxygen is this. Let me redo it. 760 millimeters. Now you are giving 40%. 40. In the ABG is expected to be around 300 for a normal case. if the gas exchange apparatus, if this thing is normal, one second. Yeah. So if this thing is normal, then we do expect that 304 millimeters of mercury of oxygen should be there in the ABG value, not 100. But the inspired air also has 47 millimeters of mercury of water pressure. Whatever we are inhaling, right? The humidity in the atmosphere, that is contributing to 47 millimeters of mercury. So effectually, I should be minusing that 47, and this is the expected value. Around 260 millimeters of mercury is the expected value if you and me are inhaling 40% oxygen. In our blood, the partial pressure of oxygen that we can take, if I am taking a sample, if I am, let's say I am putting a mask and I am inhaling 40% of oxygen, after some time, if I am taking a sample from my artery and put it in the ABG, I will be getting a value of about 260 millimeters of mercury. And this is toxic actually. You know, oxygen is toxic, right? Oxygen, human body can tolerate only 21 percentage. That is what the nature has built us. Our body is designed to accommodate only 21 percentage of oxygen. And if I am using a higher percentage of oxygen for a longer duration, then that excess oxygen can become toxic to me. That's called oxygen toxicity, and it can unleash damages in the cells. It can cause cell death. It can cause pulmonary edema. It can cause free radical injury. The oxygen will become free radicals. It will become superoxide, and that will start attacking the cellular structure. It will form peroxidase and superoxides, and all those things are highly reactive form of oxygen, which will damage the phospholipids in the cells which is covering the human cell. It will go and damage those things. Like for example, I was telling that this is the epithelium. EP means epithelium, and EN here. This EN means endothelium. Endothelium is for the blood vessel. Epithelium is for the alveoli. The alveoli is lined by the epithelial cell, and the capillary is lined by the endothelial cell. So now, if there is too much of oxygen, they can form superoxides, they can form highly reactive form of oxygen, and this can damage the phospholipid in these cells. As a result, the blood from this side can easily come into this side. Now, right now, only the gases are allowed to exchange. The blood in the capillary is not allowed to enter into the alveoli. So this is called as blood alveolar barrier. This is blood alveolar barrier. Under normal circumstance, it will not allow the blood to come from here to here, or any content of the blood, meaning the plasma, the liquid part of the blood, they are not allowed to cross this barrier. Now, because of cellular damage, because of the oxygen damage, what happens is this this protective layer will be damaged. These cells will be damaged, and they will become more porous. They will start shrinking in size. As a result, the blood will start pouring into this thing. Not frank blood, maybe the non-red part of the blood. That's called the plasma. They will enter here, and along with that, they will also carry something called fibrinogen, which will form the fibrins, or rather, it will form a scar-like structure on the alveoli, permanently damaging the alveoli. So these are the complications we should not be introducing. As a application specialist, you should be knowing the outcome of what we are doing on a ventilator. So these are certain things which is not the reason for which the patient is coming to the hospital, but they may end up in this situation if the patient is not handled properly with a ventilator. So bear it in mind that oxygen is a toxic gas, and we have to be careful with that. And how much we have to use and how long we have to use, that has to be to the bare minimum possible. So, and then we also seen the stroke volume. Stroke volume is the total volume the heart will be pumped. One beat, how much volume comes out from the heart, that is the stroke volume. And in 1 minute, the total number of beats, the heart rate, total number of beats, or the total heart rate multiplied by the stroke volume will help us to understand the total cardiac output. That is, cardiac output is the total amount of blood that is pumped from the heart in 1 minute. So this cardiac output again is something that you have to keep it in mind, because as I say that we are not only dealing with the respiratory system, we also deal with the cardiac system. That's why it's cardiorespiratory or cardiopulmonary system. Now, so this is where we stopped last week. So the recapitulation. Yeah, any query?
Yeah, sir, I just want to know, in our identity ventilator, we also have a feature of cardiac output, metabolic module.
Yeah, in our in the clinical decision support tool, under the lab calcs, you will find a cardiac output feature that is using something called a fixed principle of dilution. Let us not get into that. I mean, the cardiac output, what we are talking here is just the physiological level of cardiac output, how much blood is coming. How we are measuring the cardiac output, we have different methods, different ways of doing it. Gold standard is the thermodilution method, which are monitoring people who are dealing with monitors will be knowing that one. The one what we have in R860, it uses something called fixed principle of dilution, and it's just based on the formula. And it takes the VO2 and PCO2 data plus the SaO2 and SCO2, and it calculates the concentration of the CaO2 and CaCO2 data. It computes, and from that we are getting the cardiac output. So let us not that cardiac output, what we see in this thing. I mean, we are talking about the same thing, but the way we measure that is not considered as a standard way, and it has some inherent problems. So we don't really talk about much about it. It's just a feature to show it, but don't try to go overboard on that feature. I never discuss that. I'm just sure that we have cardiac output, and I'll leave it at that level. I will not try to dig deeper into it, because then at times you will get crazy values of 40 liters and all. The normal cardiac output will be somewhere between 5 to 8 liters per minute.
Okay, sir.
But if it is in a non-steady state, I mean, we will be talking about steady state, right? When we are talking about FRC or metabolic monitoring. If the patient is in a non-steady state, at that time, if they are doing an ABG and introducing that value, then I had seen that our ventilator reads 40 liters per minute cardiac output, which is crazy. Even elephant won't have such a kind of cardiac output. So there are a lot of precautions we need to take during measurement of that, if you really want to use that for assessing the cardiac output. And it's better not to talk about it much.
And we don't get that data, Prabhu, without the module or without aerodynamics also, is it? No, it's only the data module that we require, right?
Yeah, we need the VO2, VCO2 data. Rest of the data has to be entered manually from the ABG and venous blood. Both has to be done simultaneously, because it's based on the dilution, meaning from the arterial system, how much the vena, when it enters into the venous system, how much oxygen is utilized by the tissue. That dilution factor or the dilution coefficient will be studying and using that for computing this value. So we need both arterial and venous system. So APG generally they do artery, they just take a syringe, they just insert it to an artery, take a blood, that's it. But for venous bloodgram, the patient should have a central line, either through the jugular vein or through the femoral vein. They should have a central line connected to the patient. Only in those patients they'll be able to do this thing. And that too, if they are already connected to a central line, most likely they would also be connected to a monitor with cardiac output feature. So there they can do a thermodilution method better than trying to do it on R860 just for the sake of it.
Okay, Prabhu.
Alright, so let's move on. Any other questions? Okay, so now put these things, whatever we had seen in the past 3 sessions or in past 2 sessions and the recapitulation till now. We are talking about the heart and the lung, the cardiopulmonary thing. And you know that the blood from the heart is pumped into the lung, and the gases which is coming to the lung gets exchanged with the blood and it is brought back to the heart. So now what is this pulmonary circulation? That is the circulation between the heart and the lung. Now we are only talking about the pulmonary circulation, not about the systemic circulation which is going to the rest of the body. So this circulation which is existing, that is from the right ventricle to the heart, to the lung, and back to the left atrium. So this circulation between the heart and the lung, this acts as a reservoir of blood. So when we say that an adult have about 5.5 to 6 liters of blood totally in the body, around 20% of that blood is in this system. 80% is in the systemic circulation. At any given point of time, 20% of that blood will be in the pulmonary circulation. Okay, so this acts as a reservoir, and this is an extension. Like 40% of the blood is stored in the great veins. Totally, the venous system. If I'm seeing the total amount of blood that will be in the vein and the total blood in the artery will carry only 40% of the total blood in the body. 60% of the blood remains in the venous system, and when the great veins are dumping those blood into the heart, around 20% of the total blood in the body is circulating between the heart and the lung. So this has to be continuously happen throughout the life. The gas exchange has to be there, and you know that there is about 20 liters of carbon dioxide is dissolved in our body, and it is always there. It's a pool. It's a storage pool. Our blood, our body has a storage pool of 20 liters of carbon dioxide. Compared to that, only 1 liter is available. The oxygen, only 1 liter is stored in the body, and when we are taking, let's say, 14 or 15 breaths per minute, we will be quickly exhausting this 1 liter, because our body needs about 3 to 5 ml per kg body weight of oxygen. So suppose if somebody is about 80 kg, let's say, or 70 kg, 70 multiplied by 4, that is, every minute we need about 280 ml of blood, or around 280 to 300 ml of oxygen. Every minute we need that, and this is at the tissue level. So if we have to achieve 300 ml of oxygen at the tissue level, then I need to have 3 times that value in the blood to be delivered to the tissues every minute. So approximately I can have only 1 liter of storage oxygen in the blood. But if we stop, if the patient goes into apnea, within a minute they will be exhausting this thing, and they will quickly go into a hypoxia state, hypoxemia. That is, oxygen in the blood will be very quickly dropping down, and it can tolerate only 1 minute. More than a minute, if the patient is not getting oxygen from the environment or from the ventilator, the first thing that will happen is his brain cells starts dying, and second is the heart cells will start dying. Brain cells will start dying within 1 minute. If the oxygen supply to the brain neurons does not happen within damage, it will go to aponeurosis, and then it will start dying. And the cardiac muscle can withstand about 5 minutes. Beyond that, it will also go in for destruction. The cardiac muscle fiber will also start getting damaged, and permanently damaged, or it will die, and leading to a condition called the blood supply to them will be impaired, and if it is not corrected, then it may even end up in a frank myocardial infarction, the so-called heart attack. The second thing is, the right ventricle will act as the pump. Of course, we know that the ventricle system, this will be pumping the blood into this, and then it is distributed throughout the lung. Then the gas exchange happens, and finally the exchanged blood, the oxygenated blood will be collected back through the pulmonary veins into the right atrium, and then it goes to the left atrium. From left atrium it goes to the left ventricle, and from the left ventricle it goes to the entire body, to the systemic circulation. So this is comprising the pulmonary circulation. There are certain specific features of the pulmonary vessels, the pulmonary circulation. The blood vessels which is feeding this pulmonary circulation, they are not as strong or as thick as the systemic blood. The artery, what we are generally feeling in your radial pulse or the distal pulse, they have a very thick wall. Whereas if you look at the pulmonary vessels, they are not very thick. They are made up mostly of smooth muscles rather than the thickness what we generally see in the systemic circulation. Because this pulmonary vessels will only receive a low pressure, unlike the systemic circulation where they are exposed to as high as 120 millimeters of mercury during the systolic beat. Whereas the pulmonary vessels, at the max 20 to 25 millimeters of mercury pressure only they will be receiving. So they don't need to be that strong, that thick. They are basically made up of smooth muscles, and they are mostly venous. Since they are made up of smooth muscles, they are highly distensible, and that is why in the previous one I said that it is acting like a reservoir. It can hold a lot of blood, and it can take them for gas exchange. It can hold a lot of blood and complement the systemic circulation. But what are the influences outside the pulmonary vessels that is impacting the blood in this thing? First is the gravity. When you are standing in an upright position, the blood is a fluid, right? And they are impacted by the gravity of the earth. So when we are standing in upright position, the lower part or the basal part of the lung will be receiving a rich blood supply compared to that of the apical part, because the blood tends to cool because of gravity, and more blood will be in the way. Similarly, when you are lying down, the body position, when you are standing, when you start only the backside, that the part of the lung will be receiving a lot of blood supply, whereas the side will be receiving less. And when you are in a prone position, the opposite happens, right? So the blood, the vessel diameter, the blood, everything is influenced by the gravity, by the body position, as well as by the lung volume. If let's say there's an ARDS patient, a lot of alveoli are collapsed, and there is too much of blood in this thing, they'll form a kind of water. The blood will be stagnant there. So the free flow of blood will be blocked in those areas, and only where the pressure is normal, the blood will be entering into those places. Wherever there is a high pressure, the blood will be finding difficult to enter into that part of the lung. Okay, so that's what the alveolar pressure water. That is why when we are increasing the PEEP or the pressure in the lung, the blood will not be able to enter into those areas. Even the blood which is coming from the systemic circulation into the pulmonary circulation, they will be slowed down because of high pressure, and there will be a drop in BP. So that is also influencing the alveolar pressure, and the intrapleural pressure also influences this thing. Okay, so why am I talking about these things? Now, shift the gear and come to the lung. What happens when the pulmonary circulation, which is a part of the heart, how is this related to the gas exchange? Now, I was saying that because of gravity, there will be a lot of blood in this thing and less of blood here. So when I'm applying, like if I'm treating the lung as a single unit, and let's say I'm putting a pressure of, assume that I'm putting a pressure of 25 centimeters of water in the ventilator. So do you think that the 25 centimeters will be evenly distributed throughout the lung? Whatever the pressure we set on the ventilator, first of all, we will lose a lot of pressure in the airway itself when it is coming through the circuit to the endotracheal tube, and then entering into the trachea, and then coming down. There itself, because of narrowing of the bronchi and bronchiole, we will be losing some pressure. Now, after reaching the lung, the gases, do you think that they are evenly distributed? Because there is so much of hydrostatic pressure, because the water is, the blood is accumulating, or the fluid is accumulating at the base because of gravity or the body position. Here the hydrostatic pressure will be very high. So because of lot of blood in this area, the pressure, there has to be a high pressure to displace this blood and fill the alveoli here. Whereas here, the pressure, the hydrostatic pressure is very low here. As a result, the alveolar pressure, even a limited pressure, easily the gas can go and fill this area. Because there is less of hydrostatic pressure, the alveolar pressure can build here. whereas it finds difficult to fill in this area. So now you see that in this part of the lung, the apex, the top portion of the lung, or the non-dependent portion of the lung, there is less blood, more gas. Because of less blood, less hydrostatic pressure, and it is easy for the gas to enter there and open the alveoli. Whereas here, because there is so much of blood which is creating a lot of hydrostatic force or hydrostatic pressure, it's very difficult for the alveoli to open. Moreover, the entire weight of the lung from here to here is acting on this area. Here there is hardly any weight of the lung is acting, right? But whereas here the entire weight of this part and this part is acting on this one. So
Hey, Prabhu's sound is not coming.
Sir, I can't hear you.
I think he's got disconnected. He's not disconnected.
Not disconnected. It may not be.
voices.
There might be a network issue. Hi, Imran. Imran, you have a question?
No, sir, voice is not coming.
Okay.
Sorry, I got disconnected here. I don't know where I got disconnected. Saeed, I'm seeing your Imran. I'm seeing you raising your hand. Any queries?
Oh, yeah. Same time.
Imran, you have any query?
Sir, voice was not coming, so I raised hand.
I got dropped here. Now you are able to hear, right? I don't
Yes,
know
sir.
when I got dropped, I was talking at this thing. So can someone say that at one stage I was out? Where am I? Was I discussing this part?
Yeah, same thing, same thing.
Yes,
The bottom portion will have more weightage, the top portion will have more area to have gases.
Okay, so there are two things which is acting, more than two things acting at the base of the lung. One is the gravity, and is the weight of the entire lung. As well as less compliance means your life and different circuit dependently to this area and this area and this area. So when I apply a pressure, it's applied everywhere. And those alveoli which is able to take more pressure, that is the alveoli at the top, will be receiving larger volume. And the area which is at the basal area, dependent area, generally will be receiving. The irony here is that this is having more. Whereas here, lot of gas has entered. What happens because of that? The alveolar pressure will be too high. And when the flowing into this pressure or the alveolar pressure, the blood vessel will be squeezed like this. So the blood that can flow through this and come out will be minimized. It is actually like we are nipping it. We are squeezing this blood vessel. As a result, there is a disproportionate gas exchange will happen. That is less blood, more gas here. On the other hand, here less gas and more blood is available here. So this is leading to something called as PQ mismatch. That is ventilation perfusion mismatch. So here, if you see, we have got an excellent ventilation here. A lot of gases because of less pressure and less gravity or less hydrostatic force here. More air will enter into this thing and creating a high alveolar pressure. The high alveolar pressure in turn will reduce the blood flow into this area. Whereas here, because of lot of blood supply, we have a lot of blood here. But the gases will be finding difficult to open this alveoli because of the hydrostatic pressure and the weight of the lung. The gravity, everything is acting on this thing. So I have a lot of oxygen coming here, but the blood cannot be carrying all those oxygen because very limited blood will be coming to this area. On the other hand, I got a lot of blood which is coming to this area, but the gas cannot open this alveoli easily, so less of oxygen will be available at the dependent part of the lung. Okay, so both these areas, we call this as zone 1 or zone 3, or this is put forth by a person called West. His name is West, so it's also called as West zone. So West zone A, B call it, or zone 1, zone 2, zone 3. For our sake here, for the discussion, you see that what happens on the top. I am zooming it. At the top, the blood vessel is coming here. So this is the pulmonary artery, the arterial pressure. Pulmonary artery is coming here. It has to collect the oxygen from the lung, and then the pulmonary vein will carry the oxygenated blood back to the heart. Now we have got three systems. One is the arterial system. There is a venous system. That is, venous means is carrying the oxygenated blood. This is carrying the oxygenated blood, arterial system. Alveolar. So in this part of the lung, what happens is the alveolar pressure is higher, very high, because this is having a good compliance. Most of the gases enter here and causes a kind of effect that is squeezing the blood vessel. So you can see that effect is shown here. So the alveolar pressure is much higher compared to that of the arterial pressure. And when the blood crosses this area, the venous pressure is even more dropped. So the classic thing here is that we have got a high alveolar pressure but a poor venous pressure. So the blood that will be crossing here to here and get oxygenated and going back to this thing is not good. So in other words, you see that we are very happy that we are putting a lot of gas using the ventilator. But are doing any benefit to the patient? The blood is not collecting, is not able to get, because the blood flow itself is limited here and the oxygenation is impacted. So the blood which is going up will be carrying very less oxygen. Even though we put a lot of oxygen here, this capillary a limited amount of oxygen, so it's not going to benefit the patient. Come to this area. Now here the arterial, the arterial system. And that will be higher. This side will be higher. Only then the blood can be up. So the pulmonary artery pressure is higher here. The pulmonary vein pressure is slightly lower than the arterial pressure. But because the alveolar pressure, there is not the gas, the pressure what we are delivering is not able to open this alveoli adequately. There will be so much. But and the ABG value at this point okay, so this is called a shunting. Coming from the right side of the heart goes to the pulmonary circulation and comes back to the left side of the heart. Gas, the blood is not able to utilize this gas. So this is effectively, even though I have gas, but that is not participating in gas exchange. So this is called dead space. Okay. So two extremes are here. This will act as a dead space and this will be acting like a shunting. Now come to the middle zone. Right pressure, right hydrostatic pressure, right alveolar pressure. The alveolar pressure, the pulmonary artery is having adequate pressure, it is pushing the blood into this, and because not much of weight is acting on this area, and because hydrostatic is acting in this area compared to this is having just the right level of pressure here. So the gases which can fill this alveoli is adequate, and the blood flow into this thing is also adequate, and the arterial pressure is higher than the venous pressure, so the blood can easily flow from here to here without getting nipped like this. And since the gas can open this alveoli, unlike this, the gases can exchange. So this is the right level of this thing. So this is called as the ventilation perfusion match. In either side, we have VQ mismatch or ventilation perfusion mismatch here and here. Whereas in the middle zone, we have a better gas exchange happening in this. And this is normal, okay? Our intention of using the ventilator is to optimize this kind of behavior. I wanted to have a similar kind of thing in this part as well as in this part. And that is why we do proning. How many of you heard about proning? Your customer are talking about it. Where do we do proning? What is proning? Can you unmute yourself, and whoever knows that, can you just tell it for the benefit of the video? What do you mean by proning? Are you clear with this slide? Am I connected or?
Yes, sir. You are perfectly no.
Yeah. Anyone can tell about the prone position. This was very
Yeah, prone is
popular during the quit.
where the chest is kept on the bed and it gives more space to go inside.
Yeah, usually the patient will be made to lie on the back, right? Usually that's how we sleep. Proning means we are making the patient, we will roll the patient and make the patient to lie on the chest and the abdomen.
Yeah,
That is, the back will be facing the ceiling, and the patient's face and abdomen will be made to lie on the bed. This is an uncomfortable position for the patient, but it is very good because we are rotating. Because when we are actually making the patient to lie down, it will be something like this.
and this is very common with this ARDS patient.
Yeah,
Safe to say.
exactly. So when a patient is lying like this, his chest is like this, let's say, the lung will be like this, right? So this part, you see that this part will be acting, the base of the lung, this will be acting like the dependent area. So, what happens in ARDS, lot of fluid will be accumulating in the lung, everything will be depositing and it will keep on increasing. And it will be adding to this part flow. And more and part added. So what the clinicians would like to do is they will rotate the patient. Like let's say the patient. So this is the anterior side and this is the posterior side. Now it will be rotated the posterior and the chest and the abdomen will be on the bottom. Anterior side will be on the bottom. So now the fluid which was earlier here will be shifting to the lower part. So this will be going here. This will be going here. I don't know whether you are following what I am drawing on the screen.
So one is the supine position, other is the prone position.
The fluid is shifting to other place. So we are rotating this thing. We are not allowing the fluid and we are using all the alveoli. That is the advantage of using the prone position, which is uncomfortable for the patient as well as for the bedside team. It is difficult to prone the patient. You should have seen how they are doing the proning. You can go to YouTube and see that how they do the proning. It's a difficult process because the patient will be having an endotracheal tube connected to the mouth, and there may be some other tube like ECG leads, and then some central line will be there, catheter will be there, urinary catheter will be there. With all these things, if we have to roll the patient, also some fluid line will be going. It's not easy, but then it needs expert. It needs expertise on the clinician's part and the bedside team. They had practiced it properly, they will be keeping this entire system simple so that it is easy for them to prone the patient. So proning is really helping us. That is, we are actually trying to use this chart, what you are seeing on the slide. We are trying to make the non-dependent area to a dependent area and dependent area to non-dependent area. For some time we will put them on the prone position and sometime we turn them back to the supine position. So this is actually reducing the inflammation and reducing the total alveolar damage. So we are trying to rotate the alveoli so that one single alveoli is not taking the load throughout the day. That is what the idea of doing a proning.
Sir, yeah, in this situation, actually, for COVID scenario, happened this thing, right, sir?
Yeah, you see, ARDS, they generally do ARDS, and any patient who is having lot of fluid in the lung and challenge, proning is advised.
Dr. V, one thing I just want to just show the structure of alveoli. The alveoli seems to be embedded with the capillary, surrounded by total capillary. So one side will be affected, second side might be taking all these things like this. The structure, if you see, the alveoli is totally embedded with the capillary. So my question is that whether one capillaries or two capillaries or every capillaries is get affected by the pressure of blood accumulation or the secretion accumulation.
Yeah, it's not that we can't really think lung as a homogeneous organ, meaning it's not that single behavior. Every zone of the lung will be acting differently. And within a zone also, some areas will be acting. That is why this concept of lung ventilation or split lung ventilation and all they are talking about. These are all theoretical concepts coming out of this theoretical knowledge, but practically when we want to apply, it's very difficult to do a double lung ventilation, or they also have that liquid lung ventilation, like they use certain liquid which is dissolved, which has got a lot of dissolved oxygen in it, the low desile, something they call it. They just liquid into the patient lung. And liquid, like how the blood is gone, the entire lung is filled with the mother's this amniotic fluid. I'm getting this thing. So that is how some safe fluid. There are some articles from Mackay, I had seen that. I think we should be something they pour into the lung. That oxygen will get the alveoli. And later they will suck out that and take it out.
Or as a product, will approach the patient. This kind of situation is representing in form of high peak pressure, or what kind of the system will be displayed on the ventilator?
You mean the indication for proning you are asking?
Yes.
That's what when the SpO2 value is not increasing at all, and if they are seeing that in the general extravascular lung volume, they call GED, the global lung volume, GDE, GLW, something they say. Some of those systems will be able to identify those things, like this system able to find this the lung edema and other thing, or even a simple chest X-ray will be giving you to know that if there is too much of pulmonary edema,
Can be identified.
yeah. So they see that there is signs of fluid accumulation, and they are seeing that the bronchogram in the X-ray, if the alveoli is open, in the consolidation has happened. picture, try to open that with putting a higher beam, and also they will try to see the improvement in the SpO2 and the APTCO2 value. If those are not happening, that becomes an indication for cooling.
Typically, it is earliest of the edema
The AHS is one of the major indication. Okay. When if the hospital learns to do it properly, then they do it very routinely. And so everybody is clear with this slide.
Prabhu, one question. Need to revert back and forth after some time.
They will be pouring the patient, you keep on treating for second day, pouring back. Because as I said, pouring is difficult for the patient also.
Yeah.
But it is good for ventilation. So they will be keep on rotating the patient. It's not that they put the patient on prone position, because pressure sore is a very dangerous condition. If the patient is put on a prone position, patient is unconscious, they will be lying in that position for a long duration because of the pressure, the skin coming in contact with the bed. Somewhere that part of it will be squeezed by the bed. So as a result, over time, what happens, the temperature will go higher. Like if you are sitting in a seat, in a chair for some time, when you stand up, you will see that the chair is warm, right? Like that, if you are putting the patient in the same position for a duration, an unconscious patient not able to move, this warmth will become over time, will be damaging the skin, and it will cause pressure ulcer, pressure sore, which is extremely difficult to treat. Pressure sore is the most challenging situation to treat, and any hospital which has incidence of pressure sore is seen as a bad. Although they wanted to show zero incidence.
Okay, Prabhu. Thanks.
Going deeper, you see that this is there are alveoli, what you are seeing here, and then surrounding the alveoli, what are the small circles you are seeing is the capillary network I just showed in the previous in the earth. So when the vessel will be forming into a fluid. So this is called as the capillary alveoli. Blood vessel coming in the center of this thing, which is called the interalveolar blood vessel, interalveolar capillary, or rather this is the exalveolar microvessel. So now when I'm applying gas in this alveoli, and the alveoli is increasing in size, this central triangle is also smaller in size, and this blood vessel is attached by the basement membrane. So when there is a lot of gas going into this thing, when the inflated, you see that the wall of the alveoli, those blood vessels in the wall of the alveoli, you see that what happens to them. This one, you see what happened here. They are all getting squeezed, right? Because of the stretching. The alveolar wall, when it is increasing in size because of inflation or because of gas going into it, because of increased pressure, those blood vessels on the wall of the alveoli, they will be squeezed like this thing. They are getting squeezed and stretched out. Whereas those blood vessels which is between the alveoli, they are getting stretched. So now you see that the triangular size, because the size is becoming bigger, the triangle between this thing also is becoming bigger. As a result, the blood vessel here will be increasing in size. So this will increase the central capillary to bring more blood. But the actual alveoli, the blood vessels, the actual capillaries which is participating in gas exchange, you see that what happens to them. So this is what will be that the blood will be entering the system, but they are not going in adequately to the alveoli, so that even though there is a lot of gas in this alveoli, the blood vessel will not, since there is going to be very minimal blood flow coming through this thing, the gas exchange will not be adequate. So this is what I was calling as, what is this called as? Too much of gas and less blood flowing into that. What is that condition called?
Dead space.
Yeah, this is leading to the dead space. And if you are still increasing this thing, you see that this is the electron microscopic view of this thing. You see the crack in this thing, they break ultimately. And when the alveoli ruptures, this leads to the barotrauma and the pneumothorax. Okay, so this is the electron microscopic picture of the pneumothorax, how the barotrauma, the rupture of this alveoli leading to this condition is shown here. Now, this is the dead space, right? So now then what else can happen? Now, there are two alveoli, and the gas inside the alveoli is rich in oxygen. The partial pressure of alveolar oxygen is rich in oxygen, and there are two blood vessels, the capillaries. One capillary is coming in contact with one alveoli, so there is a gas exchange. The carbon dioxide in this blood vessel will be going into the alveoli, and the oxygen in this alveoli will be entering into the blood vessel. There is another blood vessel which is just going away from this thing. Not, it is carrying blood, but it is not participating in gas exchange. It again comes back to the oxygenated blood which is coming from here. So remember that this is carrying 40 millimeters of mercury of oxygen, and when it gets exchanged, how much will it be? 20% of FiO2. This will be about 100 millimeters of mercury, right? Because I showed that 160 or something, we say that 21% of 760 millimeters of mercury, but there is a water vapor pressure of about 47, and by the time from the nose to the alveoli it comes, there is another drop of this. So ultimately, finally, when it reaches this level, the blood will be carrying, the alveoli will be carrying around 110, and the 110, and this it cannot reach 110 because there will be a gradient, right? It cannot empty everything into this thing. So from 40, it will go through the system which is having 110, and when it comes out, this will be about 100 millimeters of mercury. This is the pure blood, or rather the oxygenated blood coming from the cardiopulmonary system. Now you see that this blood vessel, which is shunting away from this thing, which is bypassing away from this system of gas exchange, carrying the deoxygenated blood at 40 millimeters of mercury, and this is coming and joining here. So this is 100 millimeters of mercury. This is again diluting it, 40 millimeters of mercury. So the overall thing what we get here will be not 100 millimeters of mercury, it will be less than that. So our idea will be that reduce the shunt and make maximum blood to go and participate in the gas exchange. Similarly, what is the gas? The gas is coming into this alveoli, but there is no blood vessel which is going there. No blood vessel is participating here for the gas exchange. So even though the gas is coming here, without any change, without undergoing any kind of change, this is again going back during the expiration. So this is effectively a dead space. So this is a dead space not participating in gas exchange, called as anatomical dead space. This anatomy for the gas to come from the nose to the alveoli. So since this is a conduit, this is a pathway for the gas, we call it as anatomical dead space. But once it comes here, it should participate in gas exchange. But there will be some alveoli which is squeezing all blood, thereby because of huge pressure in them and not getting any gas to go into the blood at all. So those alveoli will form something called as the physiological dead space. So anatomical dead space normally is about 150 ml per breath. If you are inspiring 500 ml, 150 ml will be stuck in the anatomical dead space. Only 350 ml will be coming to the gas exchange. Ideally, all the 350 should be available for gas exchange. But if there are alveoli like this, which is having a high pressure, they can squeeze the blood vessel and ensure that no blood flows through them, so that it just comes and happily goes back. So this is adding to the extra dead space, and we will be attempting to reduce the pressure here so that the blood will start flowing here and take this. Okay, so you would have heard about the water beam, right? the intrinsic PEEP and the auto PEEP in R860. So the auto PEEP will exactly do this thing. This is why we are scared of auto PEEP. This is why we don't want auto PEEP. We wanted to find auto PEEP and minimize it, because when there is an auto PEEP, that extra pressure will be impacting the blood supply to that part. As a result, we will be increasing the dead space. So auto PEEP is directly related to the dead space in this thing. More auto PEEP, that means more dead space. So that's why we are trying to see the auto PEEP. If there is an auto PEEP, we assume that there is a dead space, extra dead space, more than the anatomical dead space, and we try to do everything possible to reduce that auto PEEP, so that we reduce this kind of impact, so that the blood will flow into this and gas exchange will be improved. Clear?
So what we can do for the different techniques?
Yeah, Sharon. Is it Sharon?
Sir, Rahul.
Rob, yeah, Rob. I didn't get your question. What?
No, we can do for the reduce our techniques.
Uh, your voice is not clear.
The question is how what we can do to reduce the dead space. Is that a question, Rahul?
Yes, yes. We have a matter, so that's why it is breaking.
Okay. So the dead space we can reduce. One is by, see, auto PEEP, what do we do for that? We will be increasing the E time. We allow more time for the gas to escape out. The expiratory time. If we are time, not wait thing to go. So just a second. Sorry, guys. Yeah, sorry. So when the uh, when the time is very short, the expiratory time. See, it takes some time for the like if you see this slide. Let's take this one. So as the gas is flowing through this thing, look at the diameter of this. And when it is dividing, look at the diameter. And when it is coming here, it will keep on reducing. The diameter keeps on reducing, right? So during inspiration, what happens? Initially, there will be a high resistance. But as the lung starts expanding, the gases will be flowing through this thing and the diameter will increase. So as the diameter increases, it is easy for the gas to come into the alveoli. It can easily come inside this. But during expiration, the reverse happens. The lung is collapsing. The diameter of all these things are going to become narrower. So now what happens? During the last few microseconds or milliseconds of the gas to escape out, the diameter would have been very small here. As a result, the resistance would have increased a lot. So as the expiration process is passive, you need to allow a longer time for the gas to go out. If you don't allow adequate time for this pressure to escape out or the volume to escape out, before even the lung is emptied, the lung's tidal volume is emptied, next breath will start and it will bring additional gas. So this will become a vicious cycle. This will keep on adding few millimeters of pressure and volume every time, to a point that this auto PEEP will start behaving as a dead space and impacting the blood flow to that area. If there is high pressure here, what happens is this will be squeezing all these blood vessels. So even though the blood comes here, it will not be able to actively participate in gas exchange. So it will just become a dead space here. So you will be controlling the auto PEEP, like you will be controlling the expiratory time, you will be controlling the respiratory rate. You have to reduce the rate. Also, we will be using bronchodilator. So why do the dead space happens? Because of some sort of obstruction, right? The gas is not able to escape out, and some of the gas are trapped in this thing. So use a bronchodilator, like the nebulizer and other thing. They'll use it, which will increase the diameter of this, and thereby makes the gas to easily go and come in this thing. If the dead space is not because of any structural damage and because of any functional thing, we can correct it. But if it is a problem, like the alveoli is completely filled with fibrin, like the blood has entered into the alveoli and the blood clot forms, and then when the blood clot is removed, it became like a fibrous thing. It became completely hard and solidified, became consolidated. In which case, even though the gas tries to enter into such kind of alveoli, the alveolar wall is so thick. I was showing you of the picture, right? This wall thickness, if it becomes so thick, then the gas will come to the alveoli, but it cannot problem. When such thing about it, then what do we do when such thing happens? I'm not able to move the gas from here to here. So what do we do? Then the dead space, all the gas which is coming here becomes acts as a dead space. No benefit to the patient. Even though I'm moving the gas from the ventilator to the alveoli, the gas will not move from alveoli to the blood. In that situation is what we will start thinking about modalities like ECMO and other things. We'll take the blood out, oxygenate it outside the body. That is called extracorporeal membrane oxygenator. We'll take it outside the body, oxygenate it, and put the blood back into the body. Okay. So those are the things. When structural damage happens to this thing, we can't do anything about it. We have to resort to some other things. But as long as it is not a structural problem, you can adjust your settings. Like you can play with your E time, you can play with your respiratory. You need to reduce your tidal volume. If there is a lot of dead space, that's because there's too much volume is okay. So these are some of the ways how we can try to address the dead space. And of course, use of chest physiotherapy. If there is any secretions which is creating this kind of thing, put a suction and clear that thing so that the gas can really go and start participating in gas exchange. All those things are the ways that we can control the dead space.
Prabhu, one question. You mean to say ECMO can partially help in
ECMO will be used when the gas exchange is not at all happening, even though you are moving the gas to the lung. But from the lung, it is not entering.
structural damage can be reduced.
Sorry?
Structural damage.
Extracorporeal membrane oxygenation.
That's right. My question is, will that help in recovering the structural damage to the alveoli? That way, or
That
why
is not
not
the target.
something temporary?
What Hari is talking about the structural damage.
Yeah. So, Hari, this is not for salvaging the structural damage of the alveoli. That is not. ECMO is the end stage care. When every option is ruled out, because it's a very risky thing. You're taking the blood out of the body, oxygenating it and putting it back into the body. There is a high likelihood you will introduce infection, and it can be deadly infection. So the call to put the patient on ECMO is that when every other modality is not doing any help to the patient, as a last resort, they'll try ECMO. And more often than not, a patient going into ECMO, we have to write off that most likely that they will not revert back. There are very less instances during the COVID pandemic time. I think ECMO has become one of the modality of choice there, because a subset of COVID patients have developed that type H kind of lung injury, which led to things like the use of ECMO and all has gone up very high. A significant proportion of patients lost when they go into ECMO. I mean, it's like it's a last hope, and very few people come out of that. It's not that ECMO is used for salvage. Breathing is ruled out. That is
Yeah. Sorry.
okay. So now put these things in perspective. Whatever we have seen, the blood is coming. The deoxygenated blood, and you can see the value here. Let's say that 5 liters per minute. It's a
So I
flow.
have a question actually.
Rahul, आप पूछो.
Yeah, who was that?
Seems to be Rahul.
सर I'm
Yeah, Rahul.
क्या सर आवाज आ रही है?
आ रही है. Tell me, Rahul.
Suppose I'm ventilating a patient, a pediatric patient. So it's at a tele volume of 80-90, and I am using a pediatric circuit, but I am using a HME of a adult HME. So will it increase the dead space?
Where are you connecting that? At the close to the white piece? Hello? Hey Rahul, are you hearing?
Sir, maybe they have network problems.
Okay.
He's unable to, but
Hello.
राहुल, तुम ट्रैवल कर रहे हो क्या? तुम्हारी आवाज बीच बीच में जा रही है. You should stay somewhere.
Sir, am I audible now? अभी सर आवाज आ रही है सर?
Yeah.
हाँ.
Go ahead, go ahead.
So, sir, my question is: suppose I'm ventilating a pediatric patient at a volume of 80 and 90, but I'm using a pediatric circuit for a ventilation, but I'm using a HME, adult HME. So, will it increase the dead space?
See, anything you are connecting beyond the Y piece of the circuit will be considered as a dead space. Whether you are using a pediatric circuit or adult circuit, that compensation is there in the ventilator. But beyond the Y piece, because there is a bias flow which is going, right? The bias flow will continue to keep on clearing all the exhaled carbon dioxide gases and keeping this thing away from the dead space. It will not allow that the artificial creation of the dead space. But anything beyond the Y piece which is not coming under the purview of bias flow, whatever you are adding a nebulizer and leaving it in situ, you are putting a EtCO2 sensor there, or HME filter or a bacterial filter, even the endotracheal tube, what we are putting, everything is becoming a dead space only. And that's why when the problem of CO2 accumulation or EtCO2 value is high, we tend to minimize these things. I mean, as less dead space as possible, we should be using it.
That's why
Definitely,
problem has been happened.
adult HME filter will add to the dead space. Yes, definitely it will add.
नहीं, क्या इंटेंशन क्या है इससे? मतलब what your answer should be या expect क्या, कहाँ क्वेश्चन पुट अप किया गया था?
सर मतलब बेसिकली ये लखनऊ में हुआ था सर. इसमें लखनऊ patient was on anesthesia and we were monitoring the EtCO2. So patient was on a pediatric circuit, and at that time the doctor has. So the EtCO2 was going to around 50, 60. अच्छा. हाँ तो वो था.
Anything beyond the Y piece of the circuit, the Y part of,
And considering it about it also adds to the resistance of the total circuit.
Okay. A question related to this: why doesn't have the neonatal mode does have? So why doesn't the neonatal mode have tube compensation feature?
compensation of what? The
Tube compensation that they keep the compensation.
tube compensation is mainly to overcome the resistance we encounter in the endotracheal tube.
Yeah, so it's not present in the neonatal mode.
Yeah,
So
neonatal because we are using uncuffed endotracheal tube. So even though if I'm increasing it, there's a tendency that unless I'm the uncuffed endotracheal tube, there will be a potential space between the endotracheal tube and the trachea of the baby. So
sure.
holding on to that is going to be difficult. So I can only be for satisfying myself. I can have it, but can I really compensate it? Is a question. No, we can't compensate because it's an uncuffed endotracheal tube. We use it in neon units.
So the composition is
We increase the peak pressure. The plateau pressure remains same, but we tend to increase the peak pressure to open up this resistance to overcome the resistance.
so what my understanding is that the machine clear has a resistance value for different type of like tubes for different diameters of tubes, right?
Yeah, correct.
And according to that, it is calculating that extra the pressure to get. So why are you doing the same thing for the neonatal patients for the neonatal
Reason would
tickets?
be, as you know that the flow and the diameter, the radius of the tube are related to the fourth power of it. Like the flow is directly proportional to fourth power of radius. The radius of the diameter of the tube becomes narrower, the resistance will increase to has to be so high to increase the thing. So as the tube diameter is so small, let's say number 4 or below that, about okay, large size to overcome the compensate it.
So in short, we can say that the modeling for this model mathematical is we can say something like that, or it's a safety issue.
It's a safety issue. The size of automated tube size of 9 or 7, for example, or the resistance 1C, in this axis we have got the pressure required, and in this axis we have got the heat flow. So in order to achieve the same kind of flow, like let's say if I want to have a 1 liter flow, 1 liter per second flow, for a 9 millimeter diameter endotracheal tube, maybe I only require this much of pressure, less than 5. Whereas when I use a 7, it will be like this. But look at this size of the diameter, like 2.5. This 1 liter.